So, welcome to Stories from Social Care Leaders, a podcast hosted by the University of Salford, which is dedicated to amplifying the voices of those shaping the future of social care. So, in this first series, we're focusing on strategic level perspectives with a special emphasis on social care nursing. We'll be speaking to key figures in the field, discussing topics such as policy, education, and research to really highlight the ideas and experiences driving change. So today we're joined by Dr. Melanie Stevens, Associate Professor of Adult Nursing at the University of Salford. Welcome, Melanie. I wonder if you could introduce yourself, maybe give us a bit of an overview about you and your background.
So thank you, Siobhan. My name's Melanie Stevens. I'm an Associate Professor in Adult Nursing at the University of Salford. I've been a registered nurse since 1991 and came to Salford as a lecturer in 2002. Since then, I've been developing a career in research, in particular in the social care community nursing sector, exploring everything from issues regarding pressure ulcer prevention and management, seating, postural care, and then more recently been exploring the impact of interprofessional education and practice in care home environment and nurse-led type 2 diabetes self-management education in Uganda.
Amazing. It's quite a lot, quite a long history there. It's exciting. So I wonder if, because I think it'd be a really great opportunity for us to kind of dig into some of the work you've done in care homes. I wonder if you'd be able to kind of chat about in a bit more detail the project that you were just talking about, the IP project that was in care homes.
Yeah, so during COVID-19, we saw this escalation of how fantastic care homes were responding to the pandemic and how they were really providing a really well-established provision of care for people who lived there, and they were held in high esteem. But actually, prior to COVID-19, care homes had got a really poor reputation in the media, which was very unfair and very unjust. Because we'd had the National Teaching Care Home Project, which really started to demonstrate the real valuable contribution care homes made to the delivery of community nursing, to the delivery of high standards of quality care, and demonstrated what a really fabulous career could be carved out for nurses within that sector. So because of COVID-19 and also because of placements decreasing in size during this time because of the way that hospitals had to respond to the pandemic, we had to think differently about student placements at the same time. So what we did is we applied for some NHS England money, previously known as Health Education England, to really undertake a feasibility study to test the concept of putting students in integrated teams into care homes and evaluate the impact, because we knew from a scoping review that we'd conducted that there's lots of research about the value of students working together in integrated teams in placements, but most of the research had been conducted in acute hospitals, particularly in Scandinavian countries, Canada, Australia, and the United States. Very little was conducted in the care home sector. And when they did go to measure the impact, it was always normally on student learning. Very little was on the impact on staff and residents. And in the UK in particular, there were only a few studies. And again, the only ones that were conducted mainly focused on student learning rather than the whole impact on everybody who was involved. So we conducted this feasibility study with 3 care homes in Greater Manchester to look at the impact of placing students in integrated teams, working with residents and staff on person-centred goals, and then measuring the impact. And we learned a lot from that about how do we put those placements together, which kind of students could go to each care home, how do we provide long-arm practice supervision, and then thinking about, well, how did the residents feel about that? How did the staff feel about it, and what did the students learn? And we also recognised during this time that those embedded perceptions that the media would like to portray about care homes actually were the initial thoughts and feelings of students when they arrived on placement, but by the end of it, they really loved the care homes, really valued the being able to really participate in person-centred care, and really held the care homes and the staff up in high esteem, which is great because then they're going back to the National Health Service with a completely different view, and they can talk to their practice educators, practice assessors, practice supervisors and say, that's not the experience I had in a care home. I had a really, truly wonderful experience and learned so much. So there was like, let's change these embedded perceptions. And then we went on to conduct a longitudinal study. We were fortunate to get further funding. So we increased the number of care homes to 5. We had these repeated cycles of interprofessional education with different groups of students, different residents, and we were able then to evaluate the longer term impact on the students, the residents and the staff. And again, learned lots about facilitating interprofessional placements, how often the multidisciplinary team meetings with the residents should run, how many residents should participate, and then how do we in a validated way measure the impact. So we've developed, unfortunately, at Salford, this survey that measures knowledge, skills and personal development of staff and students, and then good old qualitative interviews to measure the impact on the residents. So that's the kind of IP research that we've been conducting.
Amazing. So I guess there's kind of two arms to it in terms of it's kind of how powerful it is, the type of basically the provision of kind of person-centered care that it facilitates, but then also all of that knowledge and development of everyone involved as well, I guess. So it's kind of those two sides to it. Or would you say there's more?
No, I think those are like the two key things, aren't they? That this is about, when we talk about evidence-based practice in delivery of care, this IP framework proffers that opportunity that students have reflected on their experiences and said that when they've worked in the acute settings, say in hospitals or in primary care, they've very much been focused on working on a task with the practice educator, the clinical educator, practice assessor. Whereas when they're working in an IPE team using this multidisciplinary framework, they're actually developing their leadership and autonomous decision-making skills. They're having to use the clinical reasoning because they haven't got the supervisor with them all the time. It doesn't mean that practice is unsafe because there's a process of action and reflection and a process of negotiation of does this intervention, should we try this intervention, what's the evidence base around it? So you can see the connect of the students, the connecting what they've learned in the university from the theoretical sessions to what they're actually delivering in practice with the care home staff, with the residents, in helping them achieve the person-centred goals. So I think that's, for me, was one of the biggest things that the students were really learning. The other one was the students becoming autonomous practitioners, that again, there's lots written anecdotally about students. They're not coming out with the same softer skills in communication, problem solving, numeracy, IT, therapeutic relationships. So again, at this slower pace with smaller numbers of residents to care for in a team, the students have got that time to develop all of those skills. And we saw that in feedback from all the students, talking about how the time it gave them to really hone in on the communication skills, really develop longer term therapeutic relationships with the residents who they were working in week in, week out with other students. So I think for me that had a profound effect on them as well. And also that they recognise now that there was another career opportunity, that here was a sector that not many of them they might have known about it, they'll have heard about the negative embedded perceptions, but actually what they then experienced was completely different to what they'd read, which again for me was wonderful for the staff who work in those environments and the people who live there, because often seen as a last resort. It can now be seen as a really engaging, rewarding place to work and actually make a difference to the lives of people who they serve and look after in these environments.
Oh, amazing. And yeah, I guess really shows the value of giving students or students having the space sometimes, doesn't it, to like learn and grow and put those, like you say, connect those dots in real time and have the kind of reflective capacity to do that, I suppose.
Yeah, and I suppose it's moving like with community nursing, community practice. It's instead of being risk averse because everyone's scared the students are going to make a poor decision, a bad decision, is
Yeah.
actually minimising risk within a safe environment. That, you know, care homes, they've got loads of risk assessments to complete. The students were working with adults who could consent to doing something or not, an intervention that they suggested. It was always a tripartite agreement between the student, the supervisor assessor, and the day-to-day assessor in the care home, usually the care home manager or registered nurse. And therefore, everybody learnt from that and the resident themselves. So there was a lot of the students being able to reason what they were doing and why they were doing it to many people, many members of the group. So they were constantly honing in, why are you doing this? What's the reason? And having to really develop the communication skills so that everybody understood and they could gain consent to test out the theories, reflect on it, and then if it did work, fantastic. If it didn't, they could try something else. But in a, not a risk averse, but very minimising the risks, but actually enabling and promoting students to think differently.
Yeah. Amazing. And was there any, I guess you've kind of spoken about some of the key findings or the kind of most significant findings from it. Was there anything that surprised you that came out of it, or any findings that were particularly kind of stand out or
Yeah, for me, I think we've all because I've had a background in interprofessional education, I've always recognised that as nurses, we can't deliver care in splendid isolation. It's like one of my favourite terms, that we need to deliver it as part of an interprofessional team. And in care homes, there's always been a need. They've cried out for other allied health professions to help, to be part of the delivery of care. So being given this opportunity to place physio students, OTs, dietetic students, and sport rehabilitation students who not under the HCPC, but a group of students with a specific profession, is to see that actually some rehabilitation and reablement work using sport and exercise was really, really important for lots of the residents. And it really enhanced the value and the parity of esteem of what allied health professions would consider themselves the smaller group of professions in a national health service, but were seen to be integral to the MDT meetings. So that was really lovely and surprising to see their value. And I think the biggest moment is when we did it's called a Manchester Science Festival event, where it's really sharing the findings of the research at a public and patient engagement event, when we brought some of the residents back together again with the students and with the facilitators and the staff. And seeing everybody in that room together was a real humbling experience, because the residents talked to the students and they could remember them, and they were talking about how they'd still continued with the exercises, their interventions, the changes to the diet. So the students then could recognise they had a lasting impact. I think sometimes we don't see what impact we've had if we don't care for somebody for longer periods of time. And the students got to see that and felt really valued, that actually the home still were continuing with care that they'd advised, prescribed, suggested for the residents.
Oh, amazing, thank you. And what are your next steps with it, I guess, or your kind of vision for the future of the project?
Yeah, so we're obviously the 5 care homes are still delivering into professional placements when they can. Obviously, it's interprofessional education occurs when 2 or more professions are on placement at the same time. So whenever there's opportunities for that, they continue in that. I'm working with other universities now, King's College London, Northumbria University, Exeter, Bournemouth. I'm trying to think of all the others, Leeds, Beckett. So I'm working with a list of other universities who are now looking at implementing interprofessional placements for their students in not just care homes, but social care sector. I'm currently working with HC1. They're looking at conducting a pilot study in one of their homes down in, I'm trying to say, Northampton. And also then putting a large NIHR bid together with some colleagues across Bournemouth, Exeter and Northumbria University to try and get funding to conduct a longitudinal study across different regions. So looking at different geographical locations of care homes, different geographies across the country and different types of care home environments, so we can truly examine the impact across a wide, diverse population. Yeah, so they're the kinds of activities. And even thinking about replicating this model in different kinds of environments. So in Greater Manchester, we're looking at children's health and looking for getting students in integrated teams to work with families and children and schools. So thinking differently about how we can use the model in different settings.
Oh, thanks. So I guess, yeah, not just extending it in 2 ways, geographically, but also kind of contextually across different settings. Yeah, that's amazing. I'd meant to ask about whether or how homes experienced the project differently, I guess, but I suppose that kind of feeds into what you were just saying about the different kind of context that it might look different in. Was that something that kind of felt important during the study or something that you noticed during the study, I guess?
I think I've been very lucky that throughout my career I've delivered something called work-based learning, which uses action learning developed by Reg Evans. And work-based learning is all about developing somebody's knowledge, skills and themselves personally and professionally. So by taking that model but putting a multidisciplinary slant on it into students' placement experience, one, it provides the care home managers have told us, it provides them with a clear, coherent model of facilitating placements. They really enjoyed it because after an induction, students would then go and shadow staff, whereas using this model, it's an active framework. It gives the staff time to give the students actions to work with the residents, so they're not having to shadow the same member of staff all the time. They go and work with different members of the staff to really learn about the resident and how to address the goals. The students also learn about evidence-based practice. So for me, it's this using this model to think differently about how we set up placements, and that can be placements anywhere. It can be in any environment and I think as a person who's led IPE, seeing these communities of practice, it comes up in the literature time and time again as a really effective way of addressing an issue or a goal or a service provision. It just seems a natural method. So if we're going to be using that anyway when people become registrants, why aren't we using it earlier on in their career, in their pre-registration experience? So they get ready for integrated working at a later date and also can really develop the knowledge, the skills and the experiences in a safe environment.
Amazing. And did you, well, I guess as we know, research can be tricky. Was there any kind of things that cropped up, or I know we don't like to say barriers, gates that needed to be opened, we say, in conducting this study? Was there anything that kind of some of those kind of contextual factors, I guess, that cropped up that needed to be dealt with, maybe, if that makes sense?
Yeah, definitely. And I think that no, if we say that research runs smoothly, then I think we're not really telling the truth, are we? That no research runs smoothly, that it's complex. We're dealing with human beings. So human factors are a big thing because as humans, the way we communicate, if it's not in an effective way and it's not in a language and terminology that people understand, then it's going to be misrepresented. Each of the care homes have their own culture and the way that they're used to delivering placements and education. So the IPE framework is completely different. So it moves from a quite didactic, telling kind of teaching style to a very facilitative, and you're not giving any answers. You're just giving actions. The students go away, find out, and then they come back, reflect on that, and they're to be challenged on their reflections that where did they find their evidence? We had barriers about long arm practice supervision. That was and still is a task. It's a challenge because we think as registrants that when we've got a student with us, they should shadow us, they should be attached to our hip, and they should see everything and observe everything. And actually that doesn't help, because what we need to do is help them grow, because so that they don't need us anymore to become independent registrants. So we had challenges about changing the perception of what does the role of the clinical educator, the practice assessor, practice supervisor mean. There's trust in the social care sector. So if the student isn't directly with the professional who they're assigned to all the time, if they can't see what they're doing, there's this, people are risk averse and they're worried about what the student might be doing. I think there's a thought that our students are going to be quite maverick, and they're not. They're really very sensible and very safe because they're scared to do anything, so they're always checking. So yeah, communication, teamwork. This was a huge team. I think you might think it's just 5 care homes, but it's a huge team across 4 universities, 12 Greater Manchester health and care organisations, 5 care homes, quite a large research team, placement team, 32 programmes. There were, everything can get lost in translation in projects of this size. So yeah, there was, I'd say, challenges, and there still are challenges. But what I must say is that we're so fortunate across Greater Manchester that despite challenges, everybody will come together because they want to solve the problem and move forward and try and find a workaround so that we can make things happen. So I think that, yeah, on the whole, most I'd say most of the team wanted to make it happen. But we're only reflective of society. So as society, we have, it's like a continuum, isn't it? So most staff are in the middle. There's a few at the edges. So it's about winning them over, isn't it? Or not.
Yeah. Oh, amazing. And I guess you've already started to allude to this, the kind of importance of, or I guess the lack of research that integrates the voices of residents, family members, care home staff even. So, and that was obviously important to this research. I guess I just wonder what you, or how you would express kind of the importance of that or the significance of that, if that makes sense.
Yeah, no, thank you. So yeah, with the care homes, IP care home experience, we were wanting to collect the residents' experience of the whole process. Since then, I've been doing some work in Uganda using complex interventions, and what I've learned from our social scientists I've worked with, including Professor Louise Ackers, is characterisation of people's journeys. And I think if I truly had to look back now and think, would I do anything different? I actually would like to have looked at the journeys of residents, of how they ended up in the care homes. I think it was really good in the MDT meetings that the care home staff brought those stories alive for the students, which was really important, to because somebody just doesn't just appear in a care home. There's been a lengthy process of them arriving there and then settling in, and if they are still settled. And I think the care home staff were really good at telling the students that story. But I now think, as a researcher, I wish I'd spent a bit more time characterising that journey. I think it's something really good for us in working in social care, the characterisation of that, and then more. I know in our NIHR application, we've got a PPIE group made up of, it will be made up of people who live in care homes and their families and their significant others, so that we have a true representation of people who live there. So I think that's really important because, again, it gives voice to them. So, what it's like to live in a care home, what they enjoy, what they don't like, what students can get engaged with, what they shouldn't be getting engaged with, how the research should look. So I think that, yeah, I'd like more characterisation of people's journeys into social care. And then also, obviously, can't go wrong with an active PPIE group. I think it's so important for stakeholders to be part of that and helping inform and reviewing and critiquing the research as it progresses, and then helping disseminate the findings, warts and all. I like research that tells us that it's not been plain sailing, it's not all wonderful, that there are some limitations and challenges, because that's what life is. Life's not a bed of roses, it's a real mixture. So yeah.
And I guess if you never show people the I can't think about it. Show people the knots, people will never start to untangle them, I guess, will they? Those complications won't ever be grappled with in a meaningful way, I suppose.
Yeah. And we're not marketing things, are we? It's not a case of we're doing adverts for television. We're not trying to sell the product. What we're trying to sell is why research is really important, warts and all, and what we can learn even from the challenges, not just all the good stuff. So I think we've learned loads from the challenges, which can, again, the beauty of feasibility studies, then longitudinal studies, it gives you time to test your ideas and then find out what went well, what didn't, and then look at it as a longer term. So
yeah, amazing, thank you. So I know you've recently got a new post within the NIHR. So I wonder if you'd tell us a little bit about that, and how that, because I know that kind of feeds into or interconnects with a lot of the work that you've done and your kind of focus in research.
Yeah, so I was very fortunate to be interviewed and then appointed as a regional research setting lead for residential care. So residential care is quite vast, really, working for NIHR and the RRDN, the Regional Research Design Network portfolio. So I cover organisations from hospices, care homes, residential settings, homeless shelters, prisons, I'm trying to think, probation services. So it's a huge raft of different organisations that offer residential care. And really it's to support not just the delivery of research within NIHR and the Department of Health and Social Care, but also to help with increasing research capacity and capability of the staff who work there, help with any planning or placement and performance of studies. If there's funders or sponsors who are thinking of designing studies, it's working with them to think about how they might, their aims and objectives and how they might deliver the project, and is it feasible in those environments? And really starting to embed research and engagement into the residential settings, because we know, as I've said before, about embedded perceptions, actually there's a real dearth of evidence base in residential settings, and we really need to develop people's awareness of what they can get involved in, whether that's as a participant, whether somebody's a resident or an individual who lives in any of these settings, people who work there, to really think about how they can contribute to the wider research agenda.
And I guess taking that, because there's sometimes that idea, isn't there, that of people in practice or in different kind of in settings outside of academia, I guess, that feel like research is something that they don't connect with or that isn't for them. So I guess it sounds like anyway that it's kind of working to dispel that, I suppose, or to show people that they can be and are incredible at doing research probably already, but in a different way.
Yeah, definitely. I think I was in a meeting today where I said that your research can be a small R to a big R, and a small R might be that actually just implementing evidence-based practice in a residential setting is research, because you're making sure you've read up on what the latest best practice is within policy, within guidance, and then ensuring that the individuals you care for are receiving that level of care, to actually doing audits, quality improvement projects, service redesign, right through to actually conducting some research, whether that's through some studies that you're doing at a university, or, and that could be part of a degree or a master's or a PhD, or you're actually being funded by an organisation to conduct research on their behalf. So this research spans everything. People have amazing ideas. So it could be innovation. So it could be that actually they've thought of a really innovative way to manage somebody's care, or put a new intervention in, or a new kind of, it can be anything, a dressing, a walking stick, you name it, a Fitbit. These new ideas came from people thinking of a solution to an issue that somebody they were caring for had a problem with. So it's actually saying to people, let's think about what you've been, any issues you've come across and what ideas you have to make a change, and using the research process to actually demonstrate that your idea does work. Because if we don't do that, then we remain stagnant, and we're not actually enabling people to live a well-intentioned, meaningful and purposeful life, no matter where they live or being cared for. So yeah, it's those kinds of activities.
Amazing, sounds exciting. So I guess I was just going to wrap up by asking what's next. So that's quite broad. I guess you've spoken a wee bit about what's next in terms of the care home research you've been working on, thinking about that in different contexts, and the NIHR bid that you're working on. Is there any more? I guess any more? Do you have any reflections on the kind of the future of your research, or the future of care home research, even generally, the kind of shape that it needs to take moving forward, maybe?
Yeah, so I think that so many things overlap. So care home research, I think there's so much to be done. Care homes, they have obviously a rich, diverse population with multiple comorbidities. So there's an opportunity to test interventions, to test ideas, to test equipment. The wonderful thing about residents in care homes is they do want to get in. They are very interested. They don't want to just sit in a chair and watch the television. They want to get involved in interesting activities. We can see that in care homes that have they have an activity coordinator, a raft of activities going on. So they'd like to get involved in research. So it's actually proffering the opportunity and sharing what research is being conducted and how they can help. It's thinking about students, having more placements in the social care sector. So it's about universities who offer pre-registration programs, really thinking about that every student should have a placement, because then again, what we saw with lots of the students in the IPE project was they changed the dissertation topics to base them on somebody that they'd cared for in the care home, and how they could address the issues with evidence-based practice or a new intervention. So we know that that offers students a new way of thinking. And for the staff themselves, that when they engage with research and when they engage with students, it then develops them personally to see, actually, we do work in an environment that's really interesting, that's really rewarding, and we can share this wonderful environment that we offer for the people who both live there and work there. But also it makes them think about, oh, well, what could I get involved in? And we know that many homes then go on to do other courses themselves, or they get involved with their staff going through associate nurse programs or apprenticeships. So it becomes a win. I love win-wins, so we can make win-wins for everybody. Then having placements, student placements, doing research really proffers these opportunities for the care home environment. But then that spills out into the community as well, because if students have been in care homes, if they don't necessarily go and get a job in the care home afterwards, they at least have awareness of how people are admitted there, what care they receive, what information does the care home need from discharge to hospital or from the community setting to ensure that the care continues to a high quality and improves communication across different sectors. So for me, there's just so many positives of the care homes getting involved, talking to the local universities, talking to NIHR, the settings lead for their region, and joining Enrich perhaps, enabling research in care homes, the NIHR community of practice. There's lots of other ones. So it really starts to open doors, and allows us all to think differently. Because at the end of the day, if we don't constantly feel a bit uncomfortable, and if we're not learning at work all the time, then for me, we're not really becoming the professionals we're meant to be. If we know everything, then quite quickly you become bored because it's repetitious. Whereas if you're constantly learning, then you're going in work and you've always got something new to learn about yourself or other people.
Amazing, thanks so much. I know we've only really dug into one kind of facet of all the different, amazing types of work you do, but I think it's given us a really nice opportunity to get into that in a bit of detail and think, I guess, really to kind of understand and learn more about creative and innovative approaches to doing research in care homes, which is so important. So thanks a lot for your time. I'll put all the details of some of the things we've spoken about, your contact details. I'll pop them all on our website, which will be linked together with this episode. Is there any other resources or contact details, anything like that you want me to add in there? Is the best way to contact you through the website there?
Yeah, no, that'll be fine. Thank you, Siobhan, and obviously my work tribe. So I'm happy for people to contact me, and whether that's through my Salford email or through NIHR, please do. I'm happy to listen and help coach, mentor, guide, signpost to the right people.
Hopefully you'll get hundreds of emails now asking for help. Oh, thanks so much.